People also ask that why can't you give heroin also? अगर आपको फ्री में लोगों को ओपियोइड देना है कोई गवर्नमेंट की तरफ से, तो हेरोइन क्यों नहीं दे देते लोगों को? क्यों नहीं दे सकते? शॉर्ट एक्टिंग मोस्ट इंपॉर्टेंट इज दैट. सबसे बड़ी बात बुप्रेनॉर्फिन में क्या फायदा है? इट्स ओरली व्हिच मींस सबलिंगुअली इफेक्टिव, so you have to give it from a very safe route. But heroin, it has to be either smoked or injected. Both are dangerous routes. Buprenorphine is long acting. एक बार दिन में दो, दिन भर की छुट्टी. Heroin, you have to administer multiple times a day. The person will not be productive if he is given free of cost heroin. And it causes, buprenorphine causes minimum sedation, minimum euphoria. Just after 10 minutes of the dose, you are free to start walking, start doing any kind of physical activity. Under the influence of heroin, you would be intoxicated for a while, you will not be productive. In fact, heroin maintenance as a treatment has also been tried in few countries, Switzerland, UK, etc., on an experimental basis. But largely, it's buprenorphine which has been found one of the best drugs, along with methadone of course. So this is how a person's life would be if he were taking heroin. On a given day, he would be spending multiple times a day under the influence of intoxication or withdrawal. And during both the kinds of phases, he will not be productive. With buprenorphine, on the other hand, he will spend maximum part of the day without going through intoxication or withdrawal, and hence will be productive. Coming to buprenorphine, a semi-synthetic product, 25 to 40 times more potent than morphine as an analgesic, not as an intoxicant. So it doesn't give rise to as deep an intoxication like other pure antagonists would give. Bioavailability is around 50% after sublingual administration, though I think your company is supposed to have a higher bioavailability. Yes. So one of the wonderful things about buprenorphine is that it has ceiling effect. Ceiling effect बोले तो after a certain dose, its opioid agonist effect does not increase. So you keep increasing someone's dose, the effect will also go on increasing, but after a certain level, even if you increase the dose, there will not be further sort of intoxication, and hence it increases its safety. किसी का डोज अगर 10 मिलीग्राम है, उसे गलती से 20 मिलीग्राम भी खा लिया, तो उसको कोई डेथ का खतरा नहीं है. Also, it has a slow rate of dissociation, which contributes to long duration of action, and also it has low street value. Street value मतलब how much a drug user, an addict on the street is going to love a particular medicine, how much he is willing to pay, what all he can indulge in to obtain this particular drug. Street value of heroin is very high. People are going to love heroin. Buprenorphine, it's not very high. So, because it doesn't give rise as much intoxication as heroin does. Secondly, in a heroin dependent individual, it will precipitate withdrawal, and that's why it's not so popular for heroin addicts as a drug of abuse. So someone is taking heroin, which is a very intoxicating drug, and on top of it, if he takes buprenorphine will displace heroin, and since it's partial agonist only, it will actually give rise to withdrawal symptom. So कभी गलती से किसी हेरोइन एडिक्ट ने बुप्रेनॉर्फिन खा भी लिया, तो उसको कोई खतरा नहीं है इंटॉक्सिकेशन का या ओवरडोज का. Actually, he will go under the effects of withdrawal symptoms. The bioavailability by oral route is very low. इसका मतलब बच्चों के सामने से कभी गलती से किसी ने orally खा भी लिया, it will not be absorbed much. Bioavailability by sublingual route is around 50 to 70%. Metabolized in liver. Duration of action by injecting route is short, but by sublingual route it's fairly long. So what are the guidelines for using it? One is, before starting this, like Rao was also telling us, we need to wait for withdrawals to appear. If he is already under the influence of heroin or other agonist, there will be precipitated withdrawal, और उसमें फिर मजा नहीं आएगा. Then, if the person is withdrawal, then you start giving this drug. Initiate with about 2 or 4 milligram, and after first dose, it's always advisable to observe the patient for about 2 hours. पहला डोज खिलाया, उसको बोला अभी 2 घंटा आसपास ही रहो, कहीं जाना नहीं है अभी. 2 घंटे बाद फिर उससे पूछना है कैसा लग रहा है अभी, आर यू फीलिंग बेटर. इफ ही इज फीलिंग बेटर, नो विड्रॉल्स, ही कैन बी सेंट बैक होम. अगर बोला है नहीं डॉक्टर साहब अभी भी थोड़ा विड्रॉल हो रहा है, अभी भी थोड़ा हाथ पैर में दर्द है, you can give one more additional dose of 2 or 4 milligram, and then he can be sent back. And then next day you ask him, कैसा रहा, कैसी तबीयत है अभी, and then you try to determine the appropriate optimum dose for that person. That will be decided by this. If he is under medicated, dose कम है, he will report craving or withdrawal. Doctor, when I left your clinic I was fine, but by the evening I started experiencing discomfort again, which means your dose was low, it was not giving coverage for the entire 24-hour duration. If he says, oh, I was sedated, I was drowsy throughout the day, could not walk properly, this is probably he is over medicated, need to reduce the dose a bit. Properly medicated, he will be smiling, happy, no craving, no withdrawal, no other side effects, I'm totally fine. And that would be the appropriate dose for this person, which needs to continue. For how long? And that duration is not fixed. Unlike in some other illnesses, where you have a fixed dose or fixed duration of treatment, with opioid agonist treatment, there is no fixed course of treatment. The idea is the treatment should continue as long as it takes to attain the goals of treatment. And what are those goals of treatment? Abstinence? Yes. But apart from that, goal is also complete psychosocial overall in the life. Goal is also that whether you have started working or not, whether you have started earning money or not, whether you have accumulated some savings or not, whether you are looking after your family properly now or not, whether you have achieved the lost reputation in the society again or not. All these forms the goal of treatment, of agonist maintenance treatment. It's not just abstinence, we are looking at complete transformation of life of that individual. And hence, the duration of treatment needs to be as long as it takes for achieving all this. Only when the treatment goals have been met, that's when you can think about discontinuing treatment. But it is also an abusable compound. It does lead to physical dependence if taken by a non-tolerant individual for a long duration. When you stop it, it also leads to some withdrawal symptoms, which are mild, but they are prolonged. So unlike heroin, where the withdrawals are severe, Rao was showing us a graph. Heroin बंद करते से एकदम withdrawal बढ़ता है, लेकिन जल्दी खत्म भी हो जाता है. Buprenorphine, it appears gradually and comes down slowly. But this thing, the combination of buprenorphine and naloxone, that reduces the risk of its misuse. So what could be the misuse with plain buprenorphine?
Diversion.
Yeah, that's the idea. Plain buprenorphine, sublingual, the tablet can be crushed, mixed in some liquid, and then can be injected, which many people would do if they are seeking an injectable drugs high. So that's why people have tried to come up with a solution. So if you have buprenorphine, we are talking about plain buprenorphine. Someone takes it per orally, takes it by mouth. Will it act? No, because there is no bioavailability. If you take it injecting route, patient will be happy, but doctor obviously will not be happy. Doctor will not like this idea of people injecting it, and hence the ideal route of taking it is sublingually. That's when it's absorbed, when both doctor and patient are going to be very satisfied with this course of events. But patients do try to inject. So what could be the solution? Solution could be this. You mix some naloxone in it. Here, if the person takes it sublingually, naloxone, which is an antagonist, will not be absorbed. So you will have net effect of only buprenorphine. So there is patient and doctor, both will be happy. If the patient tries to inject it, there will be action of both buprenorphine as well as naloxone. Naloxone is an antagonist, so it will either not give the pleasure or it will in fact have antagonist effects. It will precipitate withdrawal. Patient will not like the effect of injecting this prevalent. The idea is to start low and go slow. This is the main difference between buprenorphine and methadone. Buprenorphine is so safe कि पहले दिन किसी को आपने 8 मिलीग्राम 10 मिलीग्राम भी खिला दिया, भले ही उसको 4 की जरूरत है, it's not going to be an overdose or an overt problem for him. But with methadone, you have to build up the dose very slowly. So this is a schematic kind of representation of prescription. For instance, for day 1 to 3, your prescription may say 10 to 20 milligrams per day. Then for next 3-4 days, you will be giving for 25 milligram. For next 3 days, 30 milligram. and so on. You will keep on building the dose until you reach the appropriate dose. And what do you mean by appropriate dose? The appropriate dose is which? Again, patient experiences no craving, no withdrawal, no intoxication, no side effects. The interesting thing about methadone is accumulation. आज आपने 10 mg दिया, कल 10 mg दिया, कल के 10 mg का असर आज के 10 mg से ज्यादा होगा, कि जो आज आपने दिया है वो थोड़ा सा जमा हो जाएगा, परसों उसका असर थोड़ा और ज्यादा होगा क्योंकि जो 2 दिन में लिया है वो भी थोड़ा जमा हो जाएगा. So after a period of few weeks of treatment, the drug starts getting accumulated and then becomes, in the real sense, a long-acting medication because of its accumulative property. For stabilizing someone on methadone, this can take up to 6 weeks or more because it takes gradual dose building, and about 60 milligram per day is likely to be the range where most of the Indian patients are likely to do well on methadone. In many Western studies, people have tried up to 120. There are individual exceptions who do require even higher doses of methadone because of metabolic issues, etc. But in general, in South Asia, we have seen people have some racial or genetic differences. People have probably different habit sizes, which means the quality of heroin or other opioids which they are taking is not very high, and hence they can be maintained on slightly lower dosage as compared to the Western studies. And when the people are comfortable throughout 24-hour period, there is no craving, no objective withdrawals, that's when we think that they are stabilized on the dose. Can there be a need to increase or decrease the dose in this phase also? Again, based on the same dose. If people continue to report some craving or withdrawal or some discomfort between dosage, that means the dose needs to be modified. About all agonist maintenance treatment, be it buprenorphine or methadone, this is something which we must always remember. और जिसको अधिकतर डॉक्टर लोग इसको समझने में गलती करते हैं. क्या है? A small dose also reduces and controls people's withdrawal symptoms, but that is not our goal of treatment. They need slightly higher dose to also address their craving. But even just reduction in craving is also not our goal of treatment. They need even higher dose to suppress further use of heroin, which is our goal of treatment. तो asking patients, अभी withdrawal हो रहा है कि नहीं हो रहा है? नहीं हो रहा है, तो तुम्हारा डोज ठीक है. That's not enough. Need to ask, craving हो रहा है या नहीं हो रहा है? Many people also believe, many people tend to forget, in fact, that craving itself is a distressing symptom which merits treatment. This was the same issue which is relevant also for the discussion of alcoholism long-term treatment. Even if the person is abstinent, person is not drinking, not taking drugs, but if continues to experience craving, that is a subject to distressing symptom which requires treatment. On a compassionate medical model, it will require treatment. For instance, when people have pain, which is a subjective condition, we do provide them painkillers. We do provide them relief from that pain, even if we do not certainly know the cause of that pain. But the distressing symptom itself requires treatment, and hence craving also needs treatment. So coming back to agonist mental treatment issue, small dose withdrawal ठीक हो जाएगा, थोड़ा और डोज बढ़ाना पड़ेगा तब जाके craving पे कंट्रोल होगा.